good evening, perhaps good morning, good afternoon. That is the new routine when it comes to welcoming people to seminars as we gather, of course, from around the world virtually for our education in this climate. I want to thank everyone for taking time out of their leisure, busy schedules, family, or whatever may be to join us for a topic that I am quite passionate about. And although it sounds intricate on the surface, I can assure you there's a broad spectrum of application here. And what we're referring to, of course, is this management of the so-called bone implant void. That, of course, puts us into this discussion right out of the gate that we are making the assumption that an immediate implant is being placed. Something that may or may not be within your purview or comfort zone, but something that I feel has become rather key, not only in the growth of my practice, but in facilitating the most ideal outcomes for my patients. So we're going to get right down to business, and I want to kind of put you or thrust you right into a situation that I think brings a little bit of a grin to most of our faces. This is one of those images where we can kind of almost just stare at it all day. It's clean, crisp, and it really represents kind of one of the most challenging portions of our care to patients when it comes to implant therapy, which is the atraumatic extraction. And you can see that this is, of course, just a snapshot. It's just an instant. It's a moment. But in this very instant, there's a couple of different emotions which are taking place. On the one side, there's this gratification, a sense of relief, but then our minds start to kind of go a mile a minute as we plan for all of the various options that it can ensue following this. Because in the real time of a surgical procedure, although this is fantastic, and again, we've made it over one obstacle, the tooth has come out in completion, and we've really done a wonderful job of maintaining the hard and soft tissue architecture. Here we are faced with the next array of challenges. And what do I mean by that? Well, they can be kind of divided into this broad spectrum of place an immediate implant or not, and simply delay things, do it in a staged approach. But on a more intricate level, think about the different options that come underneath those kind of major headings. So if you are to consider delayed placement, it's simple to say that. Perhaps you feel more conservative, more comfortable in this respect. But what does that really mean? So are you going to graft the socket at the time that you remove the tooth? Or are you simply going to do nothing and then delay it and maybe do that at a later time, or perhaps not at all, depending on your philosophy or mentality? And if you are grafting, what materials are you using? Will a membrane be utilized? Are you attempting to achieve primary closure in this instance? And if so, what are we going to do to manipulate the tissues and not cause too much destruction to the area from an aesthetic standpoint? Are vertical incisions being placed? Are we using intrasulcular incisions? Or are we simply just letting things kind of granulate in via secondary intention? These, of course, are just the beginning of a laundry list of thought processes that must take place in our mind in just an instant, because there's a patient so-called under the knife, and it's time for us to move on to the next. Now, how about if you're going to use an immediate placement? Because this beckons a whole other discussion. Yes, putting the implant in immediately may be a feasible option. It may be anatomically feasible. It may be possible in terms of your experience and your comfort. But even more so than that, we need to then discuss what takes place immediately following the immediate placement. Are you simply placing it immediately and then leaving it be using some form of temporary removable device, such as a flipper or an Essex retainer, maybe a Maryland bridge? Or are you simply just putting a healing abutment, maybe a custom healing abutment, or even fixing a temporary onto this as a solution? And then, of course, the real discussion begins, which is if you go the immediate track, well, what are you doing to manage the graft or manage the space? Do you need hard tissue augmentation, soft tissue augmentation? When should this take place? What sources do we derive this from? And so you can see, although we've stared at this kind of beautiful image for a minute or two now, there are so many thoughts that must go through our mind. And of course, the discussion in this lecture is to give some insights into the possibilities of how we can manage this both clinically as well as from an evidence-based perspective. So look at this outcome. We all love to show cases like this. We're proud of them when we achieve them. This is the, let's play find the implant game. And when you look at this, I'll take it one step further in telling you that what we've done here to achieve this is a combination of efforts, a combination of techniques, and ultimately what we've end up with is something that if I told you how we got here, and I will show this case later on, you'd probably walk away saying this must surely be the recipe. But we know that blanket solutions are challenging. And although I'm going to lay out different modalities or different options or different techniques and their rationale, pros and cons, ultimately experience, case-by-case indication are going to be absolutely crucial in achieving the best outcomes. And when we look even more closely, you can probably discern at this point that we're talking about tooth number 8 or tooth number 1-1, the right central incisor. That slight gray hue that you see is just an old amalgam tattoo or pigmented lesion from a failed root canal. But to take things one step further, this is actually a temporary state, and you're looking at the healing about 2 months out. And this is the type of response that we're looking for, and why you're going to begin to see this kind of bias into immediate temporization paired with a lot of the different socket managements that can take place at the time of immediate implant placement. So what are we trying to avoid? And we all have seen our share of complications, both within our own chairs, at our own hands, with our own patients, and of course, those that land in our chair. And for me, when I think of implant complications, it's not just failure that I'm concerned about. This is something that comes with the territory, but rather I often divide them into two kind of subdivisions with one overarching third. The first, which you're seeing in the top image, which is probably the most detrimental, is that of midfacial recession or thinning of the tissue. And here you can see that obviously the implant zeniths are at completely different points, as well as a bit of recession showing the gray collar of the implant, as well as the threads, if you look more closely, which are actually looking straight through the mucosa. And these are really very challenging cases to come back from. And of course, they tend to take place, as this one did, in young, attractive female patients with high smile lines, and she happens to, also be a high-powered lawyer. All of the recipe for kind of disaster. The lower image is one that is often talked about, kind of horizontal deformation. And this was a tooth that was extracted in an emergency scenario by a dentist and sent to us, a couple of weeks later as things begin to granulate in. And we don't have the option of the immediate implant anymore. But you can see that there's going to be some degree of deficiency. But, as much as so many providers love the idea of building mountains of bone and mountains of tissue, I often question whether this is a patient-oriented endeavor or whether this is something that we are doing kind of for our own ego and our own capabilities to show what it is that we can accomplish. And for me, this secondary goal of horizontal augmentation, of course, there needs to be an adequate amount of bone for the implant to be housed in, but it's not necessarily for me something that needs to be really emphasized drastically, because all of these play into one important factor, which is what I value as a private practitioner, and that is we want to make sure that patients are satisfied, because a patient who's unhappy, whether the implant in our eyes is a success, is a failure to them. And that's why we're going to go through some of the motions or some of the discussion about how we can optimize our results, not only for us as clinicians, but of course for our patients, who are the ultimate drivers of our practice. So let's put you right in the driver's seat. We showed you the atraumatic extraction. This is the same case carried through as at the beginning. And what you're seeing here is the implant being placed for you. So I am now telling you, not only have we elected to place the implant immediately, I'll tell you that we've achieved a high degree of primary stability. We are now faced with this so-called bone implant void. And again, many options may exist before you. I'll go ahead and preface this one step further. A common question that is normally asked when we are going to be tackling a case of this nature is the buccal plate intact? And for the purpose of this conversation, this short seminar that we're trying to capitalize on kind of a very narrow indication, we're going to talk about this being intact. And some of you may be familiar with these kind of socket classifications, where a type 1 socket basically represents that of both the hard and the soft tissues being intact, versus type 2, where the soft tissue is intact, the bone is missing, or type 3, where both are deformed to a degree. And you may be saying, well, how is he just talking about type 1 sockets? When do we ever get the luxury of that? the truth is, in the aesthetic zone, I find that these are actually quite common because we do see patients who have had fracture, trauma, or even crowns, root canals that have been kind of long held in place, and then finally that crown has come off for the last time. They've added that third additional pin or post, and it's deciding to call it quits. So I do find that these crop up rather frequently, and they are things that we want to be able to capitalize on. So what are our options? Where can we go from here when faced with this scenario? And again, this list that I've put before you is reasonably exhaustive, but it doesn't come from a journal or from a textbook. These are from kind of top of mind, the things that would be in my armamentarium or going through my head when faced with cases like this. And they range everywhere from doing nothing, of course, to doing something. Some of them are more on the surgical end. Others are on the prosthetic side of things. And we're going to walk through each of these. And I think that we need to start with the most important thing, which is doing nothing an option? Because there are many who believe less is more, and allowing the body to heal through a natural cascade are things that are feasible. And we want to understand why that may or may not be advantageous to ourselves and to our patients. And to know that, we do have to take a quick, brief look at what I think is a key paper. Depending on your level of expertise or experience, you may think it's feasible, and I can recall being in my residency and thinking, we oftentimes tell patients if they put an implant in that it helps to maintain bone in an edentulous area versus further atrophy. Whether there's truth to that is a whole other discussion. And when it comes to immediacy, perhaps the thought process, or you may believe that simply placing an implant will stop the cascade of kind of deformation of the morphology of the socket. We know when we take out a tooth that there's going to be changes where you're going to lose horizontal and vertical dimension. And once upon a time, it may have been believed that simply placing an implant immediately would actually circumvent those. We know this is not the case based on Arrojo and Lindy's paper, and it's a histological study which used dogs to show that at a time point 1, when an immediate implant was placed, and here's this line across the top, what they saw some weeks and months later was that there was a deformation both in the buccal and the lingual sides, and you can see the arrows dropping down. But what's important to derive from this alone doesn't tell you that you can't place an immediate and do nothing. It just says that you're going to see changes in the amount of horizontal and vertical bone that you have, but the implants are still housed within bone. So some may argue that for other areas of the mouth where the stakes aren't as high, this may be a feasible option. But when we talk about whether or not we can do something or do nothing, what we're really referring to is something that people like to call the jumping distance. And the jumping distance is essentially this space here. It's this bone implant void, and it's a colloquial kind of surgical implant term, which represents what are the chances or how big is this space that it may fill in spontaneously. And most of us who have familiarity, if you dabble in the implant world, then you kind of reach and grab this number of 1.5 to 2 millimeters, and it's not wrong. There are many instances of showing this in the literature that this will spontaneously fill. So if this is the case, if it will spontaneously fill, where is the debate even? If we know the measurement is less than this, is it even worthy of discussion? And I think that it definitely is, because we need to think and look at the way that we place an immediate implant. And of course, that's not the scope of this discussion, but it does kind of warrant at least a little bit of a review. So we oftentimes place our initial osteotomy. You can see we are intentionally going into the palatal bone, and we're on an inclination that would not be ideal for prosthetic placement. Once that is done, we don't place in the socket proper, and you'll see this, and our initial osteotomy is created, we begin to kind of orient things in a fashion that will allow for a screw-retained final restoration in a more prosthetically appropriate position. And finally, when we place the implant, something that is very key is we begin on this initial anglination, and then we actually kind of change or alter to compensate into the right position. And this can be shown here as kind of an overview. And I think this is really important to understand the drilling as well as the placement sequence that puts us into the appropriate position. Otherwise, it can end up on the buccal aspect. So what happens once we've gone through our preparation, we've extracted the tooth, we've placed the implant? Of course, we have this so-called bone implant void. And whether or not the jumping distance is adequate or a clot will spontaneously fill and bone will form is actually based on two principles that are a little more technical in their terminology than jumping distance, but they are really what's happening at a biologic level. We're talking about distance osteogenesis and contact osteogenesis. Distance osteogenesis basically means that bone will form at a distance from the buccal plate toward the implant. And contact osteogenesis refers to bone that is actually developing on the implant surface and working its way towards the buccal plate. So you can imagine that there's almost like this race or this convergence of the bone developing at a distance and the bone developing directly on the implant surface. Whether or not they meet, merge, and create bone will be whether we create this spontaneous fill. And so I often analogize this by looking at this map of Saint Martin. And what does this have to do with implantology? Well, for those who have been there, it's a beautiful island, and it's half French and it's half Dutch. And I was visiting there during my time in residency, and one of my classmates who was from France asked me if I knew the origin of how the island was divided amongst these two countries. And as the story goes, apparently the fastest runners were selected from each country many, many years ago. And as they began to sprint towards each other, wherever they met, a border was established, of course inferring that the faster runner from the country would get more land. To me, I'm not a politician, I'm not involved in geography. This seems like a pretty absurd way to establish a border. Surely there must be more valuable methods at gaining an actual division. So when I think about this kind of argument or discussion, or how much emphasis is put into the literature of jumping distance and this exact 1.5 mm, 2 millimeters, for me, these so-called rules, I'm in a practical application when I'm working in my practice, and I'm not breaking out the probe to measure a fraction of a millimeter. For me, I don't want to wait to see the contact and distance osteogenesis, whether or not they're going to meet. I want to know this is going to fill when I'm staring at those bare threads. And my suggestion at that point is I just sleep better when I go ahead and graft this portion, when I graft this so-called bone implant void. Because, there are papers that tell us it can be even larger than this and it will get spontaneous fill. But those are means. And if we are one of the outliers, which goes one way or the other, we're not going to want to have to manage those type of complications in our patients. So I think doing nothing is not the greatest thing. And to give even a little bit more merit to this, of course, all of us has found ourselves down the kind of rabbit hole of webinars that are available during COVID. And this is Laureen Langer. Many of you may be familiar, but she's a giant in the field. And there was a lecture that I was watching talking about immediate placement. And she gets to this point of whether or not you should graft. And it says, why graft? And she's listed all these papers on the side. And I'm waiting for this extremely intricate explanation or indications or when and why. And she says, why graft? And then all of a sudden she just says, why not? And I think that I really share this rationale with her and many others, because we don't want to leave things to chance when it comes to biology. We want to kind of augment those. So we can kind of rule out this idea, I believe, of doing nothing, at least in the aesthetic zone. And with that, we'll kind of move on to what I think is the mainstay of my practice and the way that I tackle these situations, which has to do with hard tissue augmentation or hard tissue kind of placement at the time of doing so. And these come in different forms, ranging from auto, allo, xeno, and synthetic. When it comes to this type of indication, I think that most of us are not going to a secondary site to harvest from the patient, and most people are not using synthetics. So it comes down to allografts and xenografts. And I've had my kind of ups and downs with each of these products, and I've used both with a pretty good degree of success, but want to show you some of the differences in terms of the healing that you can expect if you're going to be utilizing these materials, because again, you want to make sure that you're aware of what's happening and getting the best possible outcomes. So let's get into the casework to show the display of each of these kind of routines. This is a case that is, to me, rather challenging. When it comes to implantology, we know that black triangles, recession, and thin tissues are a very, very, very difficult situation to rectify. In fact, when I look at this and I have the discussion with the patient in consultation about where we go from here and what to expect when managing their expectations, I'm quite forthright in telling them that my goal is actually just to make sure that this doesn't get too much worse than how it looks. And by only treating the one tooth that's a problem, and we're talking about tooth number 8, the right central incisor, tooth number 1-1, this is something that is a challenging case, and you have to talk in detail about patients and point out some of these deficiencies to them, that the zenith is longer, that the gums are a little bit thinner, and that there's black triangles that may even get worse when we carry forward. And you'll see the outcome of this case that you may not qualify as kind of brilliant, but I think is a very realistic situation of what I believe is one of the best case scenarios we could have actually achieved. And here's the tooth, and it goes back to some of those discussions where I had talked about, how many more pins, how many more times can the patient sneeze, breathe the wrong way, and this thing comes off. Eventually, they reach a threshold where they decide they want to actually pursue this. And so notice the initial contours, and this is, of course, something we're striving to maintain. And here's the tooth removed atraumatically. You can see that that word atraumatic really does mean that no incisions are laid, no flaps are raised, and we're doing everything possible. Now, this is quite a thick tissue biotype if you look at this. And that's why you'll see how I've managed this case in particular. So we go ahead and we ready our implant. And this is a Straumann BLX implant, which is really well indicated for immediate placement, high primary stability, and for immediate temporization. And we go ahead and we're gonna kind of put this thing in at a high torque value and move on to the next, which is the grafting. So the management here takes place, and this is an allograft that I've used. This is a kind of small particle allograft, Straumann product from LifeNet. And you're seeing a healing abutment that's placed simply to allow the condensation of this material at the time that we've placed the implant, so it doesn't go into the actual connection of the implant. But this is not staying on, because what's happening behind the scenes is that a temporary has been kind of flowed, or what we call picked up, and we take it from being in this sort of a state to this sort of a state, and ultimately this is the healing after 2 months' time. And you can see the tissues are really beginning to mature, and even more so at 4 months as we move towards the final. I mean, you can see the degree of tissue thickness that has happened here. And recall, there has been no connective tissue that has been used here. And again, this was done based on the fact that we have a large jumping distance, or a large gap that we were able to fill. We utilized something we refer to as kind of the dual zone technique. So the graft material is built up almost to the threshold of the margin. It's kind of overbuilt. And you can see that the contours have really been maintained. And this type of soft tissue thickness, whether or not it's exactly the same amount of horizontal that was there previously, this is really what we're going for. And, here is the tissue condition. Here is the situation at 2 weeks. Now, I want to show this because there's a good learning point here, which is that oftentimes those black triangles are still going to be present. And this may appear discreet to you, but this will, if the tooth was removed atraumatically, if bone was intact to begin with interproximally, this will begin to improve. Now, this type of situation, you can see that it's robust. This is still the tooth in a temporary state. Things are going to continue to get better from here. And radiographically, we're looking at the situation the day of placement, 2 months and 1 year. And I think you'll probably note that this is a rather slender implant. This is a 3.5 millimeter diameter implant. I use this routinely. It has the strength properties, and it allows for more bone, more soft tissue between the interproximal areas. I think most of us are moving or starting to favor narrower implants when possible. And this is a rather long implant, which was needed for the purpose of achieving stability on the day of. To kind of sidetrack to a similar but different case, and I want to kind of ignore the fact that we're dealing with 2 teeth, because this is something when it comes to adjacent implants that beckons a whole other point of discussion, but rather, again, same principles, rather thick tissue, atraumatic extractions being performed, Implants are being placed in the appropriate palatal position. And here I'm going to show material that is from Straumann as well. It's something called Xenoflex, and it's actually a collagen impregnated xenograft. And what's really nice about it, and you'll see here, is that it has this wonderful handling property. You can't usually pick up particulates with a set of kind of cotton pliers or tissue pickups. And you can see that you can really condense this. I don't want to equate it to something like a sticky bone per se, but this is a really nice material from a handling perspective. So it's a xenograft that has collagen in it. And you can see we're just going ahead and we're condensing this around. These are the temporary copings which are on because we're preparing for, of course, immediate temporization. And I'm just taking little bits at a time, and you can see some of the area just being condensed. Now, here's what it looks like, and you can see the overbuild. And maybe I went a little bit excessive. And this is one of the challenges I find with xenograft. On the one side, I've long believed that you want to use a product like xenograft because it doesn't turn over, it doesn't resorb, and really, I'm not trying to achieve vertical ridge augmentation. I'm simply trying to create a mask or tissue thickness for my implants, which are completely integrated regardless. But because of that slow turnover, there may be a different healing period. Now, here's the temporary again from shell to final, and here it is being inserted, and it really gives some degree of understanding of kind of how atraumatic this procedure is. And really what patients come in, how minimal invasive it is. This is how this patient's going to leave in the chair this day. You can see the kind of passive fit. We typically screw these things into a firm finger tightness. You can see I'm working back and forth between the two to make sure that it's completely seated. But this is really the type of result that we're looking at. Now, how does this thing begin to heal up? That's a whole other discussion. Here's the patient 2 months later. Now, this may get some people startled. I have built a little bit of a tolerance. You can see the tissue thickness is built. Oftentimes in dentistry and medicine, we always say, time is the best medicine. This was a patient who allowed me to do something I don't always do. Some people would debate that you should begin to curette or remove these particles. But she was unwilling to do so, very nervous in the chair, had sedation for the actual surgery, and to do this kind of comfortably would have required some degree of local anesthesia. So she said, please leave it. Please don't do anything. I urged her to continue brushing. So she comes back, and here we are at 4 months. And you can see that things are beginning to improve. I still don't love it. At this stage, I'm saying, please just let me go in there. Let me pick out a couple of these small particles. And she rejects this. So a nice little case study to show what happens. So sometimes when we say time is the best medicine, perhaps it is. And here we are kind of showing this 2 months, 4 months, 6 months evolution of using this material. So when it comes to using xenograft products that take longer to turn over, I think this is something that you must kind of bear in mind, as opposed to the earlier case where I showed the allograft. It seems to become resorbed into the tissues or turned over and taken into the tissues with a little bit kind of easier or shorter period of time. But of course, a great result achieved regardless. And when we look to literature, there is no shortage. The papers go on and on and on that show us that when you use bone grafts, it will help to reduce the horizontal changes that occur following immediate placement to kind of basically stop or minimize the amount of horizontal bone deformation that would otherwise take place. So let's kind of put hard tissue behind us and quickly touch on partial extraction therapy. We'll then come back to soft tissue management. This is a very brief interlude, and the reason is because I actually have little to no experience with this. And I mention it because I think it is a growing field and it carries importance. But when it comes to it, and this is what it looks like, for those who aren't familiar, it's maintenance of a small shield or a portion of the buccal portion of the root of the tooth to try and keep the structure or the hard and soft tissue kind of structure. And this is a complication by another provider which was sent to me. And I would never make the comment that that complications don't take place with just about any type of technique that we use. But this is where it really scares me. And what had happened was this had kind of come loose for whatever reason. And ultimately, this is a scary endeavor in this area of the mouth to try and tackle. So that was kind of pushed me away. And then another trusted colleague and mentor and friend, Dr. Joseph Kahn, who many of you are familiar with, was recently having one of these live discussions in a webinar again. And his mentality was shared very similar to my own, which is he says, are we creating a solution to a problem that doesn't exist? Meaning, not that I'm against the advancement and I'm always on the edge and trying to push forward and evolve my own kind of techniques, but is it possible that we're just doing something that it doesn't add that much more merit? I'm not sure if that's the case, but this is my mentality and I'm kind of on the brink of wanting to try this, but not just there quite yet. Soft tissue is another important factor that must be considered when we are placing implants and of course around natural teeth. And what does that mean and why do we do it? There are some people who use this as a blanket approach, meaning if it's in the aesthetic zone, they place a soft tissue graft because they simply don't want to have complications or issues. There may be some degree of merit to that. I'm not certain. So what are the various options that exist to us? Same as previously with the hard tissue augmentation, allografts, autografts, xenografts. But for the purpose of today's discussion, we're really going to zone in on one zone tissue. And when we look at a case like this, we perform our atraumatic extraction. Here you begin to see that the tissue profile is a little bit on the thinner side. Oftentimes, people will speak to 2 millimeters being the minimum that we want to have in order to ensure that there's no gray show through and the implant threads or that kind of discoloration is not aesthetically unappealing to the patient and of course to us. The other thing is that we know that thinner tissue biotype can be at greater risk for recession. This is where I begin to consider implementing this as opposed to across the board. We often harvest from the palate, and here you're seeing two different techniques, kind of a use of a single incision or what we now call like a de-epithelialized technique, where we take a portion of it and we're actually removing the epithelial layer, so it's harvested much like a free gingival graft. And then here you can see we're removing this most superficial portion, and this will be placed after the immediate is done. So same pickup, same type of technique, and then here is the placement along the gingival margin or just within. And this is being done strictly to bulk the tissue up. And we can go from this to this. And of course, this is this case that I showed you at the outset. And you can obviously see the degree of predictability, the nice, thick, stippled pink tissues that we've achieved. And I think that using soft tissues is something that should be considered. And again, I never take away from the fact that this may be a direction that I'm heading and that ultimately I may utilize. But I often talk about practical application, and patients do have a threshold, even though we want to do right by them. And of course, there's no shortcuts involved. Every time we add an additional cost, additional procedure, and a second site of morbidity, a third site of morbidity, these are things that are going to drive our patients away from the care that we want to be able to deliver them kind of efficiently and predictably in a so-called patient-centered fashion. So for me, what I look at, and this is a great paper that kind of touches on this, if you look at the comparison between the degree of recession, which was found, or the frequency between different groups, it had to do with thick or thin tissue biotype. And what I've circled here is that those with thick tissue had around 0.5 millimeter of recession, which one might consider kind of acceptable. And those with a thin tissue biotype had as much as 1.5 millimeters of recession, which is, of course, going to make a big difference when we're in the aesthetic zone. So let's get into the kind of the last aspect, which moves away from the surgical side, although you'll still see the same type of implementation in terms of the way that we carry out the extractions and the workflow. But rather what we're moving into now is this discussion of what type of prosthetic options, whether they be true immediate temporaries or others, can exist to help to maintain the hard and soft tissues so that we can end up with the best possible outcomes. Now, some people may be watching this and saying, great, I tuned into this and everything he's showing is immediate temporization, immediate temporization, immediate temporization, and I don't have the experience, I don't have the wherewithal. I'm very fortunate we have a lab within our clinic, but this can be done chairside with relative ease and of course practice. If you're unable, for any of the reasons I just mentioned, comfort-wise, experience-wise, not able or not wanting to try and endeavor in doing immediate temporization, putting on a fixed provisional, I would highly recommend consideration for something like this, a so-called customized healing abutment. And the reason is that we know that your typical stock healing abutment, albeit helpful, is not going to provide the same level of support and ease of impression, and then, of course, seeding of the final restoration. So this doesn't necessarily have to be done in every single circumstance, but certainly in the aesthetic zone, this is something that's really going to improve your outcomes and can be done with minimal cost, time, chairside, or in advance, as these have been fabricated by a laboratory. The next piece that's key is that if you are going to go the distance and consider temporization, you need to understand the influence that emergence profile, that is the way that the tooth comes out of the gums, the shape, the form, is going to have. And oftentimes you'll hear people talking about these intricacies, what they call the subcritical and critical contours. The critical contour is the one that's, again, considered to be critical because it's basically the edge of the crown that is at the level of the gingival margin, whereas the subcritical contour is found just beneath that. And depending on how you manipulate these in terms of under contour, over contour, kind of bulking or taking them down, you're going to put yourself in a position of being able to drive the tissue in different directions, either favorably or unfavorably. And I'm going to try and show some cases of how we use these to our advantage, and sometimes even too much so, to gain certain types of changes. And here's a younger fellow who had an accident playing hockey, took a stick to the face. You can see that the dentist has gone ahead and bonded these together using a splint, but ultimately the tooth requires removal. And this is the day he comes for photos and impression. And then by the time he comes back, even a couple weeks later, you can see the body is starting to reject this. There's an inflammatory process which is taking place. And there's no question that we have a slight gingival discrepancy. Now, this may have not caught your eye right out of the gate, but he had actually brought it up, saying he's always felt this tooth is longer, and could that be corrected? It makes the stakes higher, and it makes it challenging. Even with a thick tissue biotype, even with a minimal amount, the tendency for implant-related tissue is to move coronally, to remove upwards. I apologize. So here's the situation, and you can see the beginnings of the osteotomy. You can see the tooth is obviously is beyond repair, and we removed it as we have in the past with minimal manipulations of the tissue. And you can see the beginnings, as I said, of the osteotomy in the palatal position. So the implant is placed, everything is kept intact, and we go ahead and we overfill, healing them up in place so that the material doesn't get in there. This is, again, that Straumann XenoFlex collagen impregnated material that we're using. And you can see from this image really how much we've overbulked it. Now, what happens next is we go through the usual workflow of kind of taking the temp from this so-called pickup position as a shell. These are resin-based, and then they move their way on to coming back in the more final state. Here it is inserted, good prosthetic placement, emerging from the cingulum, and you can see that the tissue looks fantastic in terms of the bulge. We kind of overpack these things. Now, here's the contour. Here is on the day of placement, and you can see very subtle change. What we did out of the gate was to put this kind of gap or under contour, and what it's showing there is the opportunity for these gums to come down. There's no coronal advancement being performed, there's no incisions, no connective tissue graft. We're going to let Mother Nature take its course, but we take an interesting turn. Here's on the day of placement. This fellow, we ask for compliance. People ask what happens if patients don't listen. Had gone ahead and chewed on this, and it came loose. It's an interesting case because it shows us kind of where we go in cases like this. And ultimately, when I went to put the temporary back on, I really felt that I was shoving the gums upwards, so much so that I was going to end up making this look longer as it had initially. So a very subtle change was made. And what you can see right here is there's a little notch or an under-contoured area which has been created. And this is what happens a few weeks later. Look at how the gums have come down. Now, you might be looking at this and saying, that's really not aesthetically pleasing. But this is the situation you want to be in to be able to make up ground. It's always going to be easy to go the other way, not so easy to always come this way. And sure enough, this is the original tooth kind of silhouette overlaid to show you the changes, significant. And you can see we've actually created the reverse situation here. And this is the tissue form, a couple months later. And note again, you can see some degree of those particles still there a couple months later. So they do stick around, kind of be aware of that. And here we are a couple months later, things are looking good. just a different angle to show. It looks like some small piece of seed or food has gone underneath there, but these are the tissue contours we're really looking for. Here's kind of this recapitulation. And look, you can see that we're getting it longer and longer to show you all the way through from the top image where we had shortened it. Now we're making the temp longer and longer. We're going to get ourselves back into a position to make things almost equal. And another case for kind of interest's sake, here's a situation again where the central incisor you can see is longer and the patient's concerned about it. Atraumatic extraction, placement of immediate implant. And look here, you can see this gap that is left. We're going to let the body take its toll. And the same type of workflow when it comes to these immediates is being undertaken. Here it is from an occlusal view. You can see this recurrent management. No soft tissue graft was placed here. We did bulk things up. This is back to using an allograft in this case, and things are going to be left to heal. And here you can see the temporary being placed. Look at the particulate material right up to the gingival margin, perhaps even beyond. No membranes being used here because we have the containment as well as the temporary to hold things in place. And for those that are of the mindset that you shouldn't make your temporaries nice because patients will not come back if they're too well done, we're of the exact opposite mentality. And you can see the character and the care which has been taken by the lab to create almost an identical tooth. And this is really a piece of art. And you can also see or note the small under-contoured area which has taken place to allow for the tissue ingress and to put it in a more appropriate position to create symmetry. So I want to kind of close with this paper that I think is really relevant, and it absolutely encapsulates everything we've discussed. What they showed was they divided patients. Every patient receives an immediate implant. Some of them get healing abutments, and some of them get immediate temporaries. The ones with healing abutments, they divide in two. Some get a graft, some don't get a graft. And the immediate temporaries, some get a graft and some don't get a graft. And what do they find in terms of the best tissue volume and in the best aesthetics? They found it's the people who had the provisionals and in combination with a graft that kind of fell into this group. And that may sound obvious, but this is the type of thing that we are kind of instituting on a routine basis. So when we go back to this initial case and we talked about extracting the tooth and we talk about placing it immediately, and you're faced with this situation before you and what to do, I think and hope that this has at least shed a little bit of light on the various options, the pros and cons, and when and where each of these may be indicated or have benefit in order to help you achieve better outcomes. Where we don't want to end up is a situation like this, and this is one of the earlier cases. These are really hard to come back from, very, very, very challenging, and ultimately they end up looking something like this, not the type of treatment we want to be rendering or trying to kind of improve upon. So we want to end up with cases like this, and you've seen some of the staples or modalities involved in achieving these types of situations. So, I was recently watching a series about a chef named Francis Malman, and he's a Patagonian gentleman, and he had a quote, and I know it's very cliche to include these in a lecture, but it really was important to me and resonated. And he said, in order to grow and improve, you have to be there a bit at the edge of uncertainty. So for those of you who may have different degrees of comfort with immediacy, with some of the grafting that I performed, in order to get patients the best possible outcome, you sometimes do have to step outside your comfort zone into new territory to push yourself into that so-called edge of uncertainty, if you will, in order to get the best possible outcomes for our patients. So I thank everyone for their time. We, of course, welcome any questions at this point in time. If you'd like to reach out to me directly, this has become a little bit of a habit and perhaps novel to some, but now normal to myself. But Dr. Phil Walton, or at Dr. Phil Walton on Instagram of all places. I really encourage you to check it out. There's so many interesting cases being exchanged. It's a wonderful platform for education, and you can reach me there directly with messages about some of the cases you've seen tonight or your own cases. I'm always there as kind of a sounding board. I know how important it is to implementing new things or adopting new things in your practice. So again, thank you so much for your time, and I look forward to your questions. So let's take a quick look. I'm just going to flip over to the questions page here to take a glance and try and field some of these. Again, I hope everyone enjoyed the chat. One of the first questions that I got, and I think it's definitely a good one, is in discussion about the actual temporary copings that we're using throughout these procedures. And you saw pretty much a kind of a uniform or single workflow that I was doing in consequence with the Straumann BLX implants. And the person asked whether I was using PEEK abutments. PEEK is a great material, and I have used it historically. What you're seeing here, and why you may have been caught off guard, is that these are actually the metal temporary copings that are offered by Straumann. But one thing that we do, and I've obviously talked about the extent, in an effort to try and maximize aesthetics, is that we actually have our laboratories use opacers. So that is why they appear white, which isn't the way that they necessarily come stock. So this is just one added thing, and why it may have appeared that it was one of the polyethyl keter. So when doing this, you can use the PEEK abutments, but we tend to use the metal ones. And on to the next question here. So someone had asked me whether or not I use a membrane over the graft when we're doing this so-called dual zone technique, or filling in the bone implant void with particulate, whether it be allograft or xenograft. And you kind of saw some of the pros and cons that come with each of those materials. When it comes to putting a membrane, I can tell you that historically I actually did, but that was when I was only placing a healing abutment. If you're not in the position to be using a customized healing abutment or a temporary, as was seen throughout the lecture, then it's important that you seal it with something. And again, whether it's truly a barrier membrane or whether it's simply a temporary, as you've seen, this will allow for containment of the graft and for formation of kind of this, I guess it's both bone and tissue encapsulated, that creates this thickened soft tissue that we desire. So I do not use a membrane in conjunction with this approach, but if you are not using a temporary, then I would definitely suggest doing so. All right, next question. I was asked what resin material that we use to create these provisionals. So you saw the workflow pretty intricately. Obviously, in a 45-minute window, there's only so much we can show you. I apologize. I'm not the type of guy who's a secret sauce, doesn't show behind the scenes. If you actually pop onto my Instagram account, you can see stories or highlights, which really show things all the way through in even greater detail than that was seen in the lecture this evening. But the resin that we use is something called Radica. I work in Toronto in Canada. I know it's readily available here. My assumption would be that it's also available in the States and other parts of the world. And it's something that has worked nicely for us. You can get a very high polish and finish, whatever material you're using. And part of the reason we prefer resin over acrylic is that to do this right and to have a subgingival portion of the temporary, it needs to be intricately smooth. Otherwise, any porosities, imperfections will lead to soft tissue challenges, inflammation, and things of that nature. So I highly suggest using resin over acrylic, and the one that we tend to favor is something called Radica. I was asked, what is the minimum ISQ that you need to place a provisional? So I'll look at that kind of in two steps. The first is that we use ISQ. Unfortunately, we don't use it every single time. And, that's something that we should. We actually, which is somewhat improper, use ISQ a lot of the times before final loading. We typically go off of Newton centimeters and torque values. And depending on the individual that you speak to and their comfort level, and of course, the given case that they're working on, you usually hear the number like 30 or 35 Newton centimeters being a minimum Newton centimeters or torque value, so-called primary stability. I can tell you that with implants such as this, with very aggressive type of threads that are designed for high primary stability, I'm not shy to be achieving at minimum 35 and going well beyond that into 60, 70, even 80 Newton centimeters. I like my implants to go in tight because of the type of practice that we run, where we're doing a significant amount of our cases with immediate temporization. In cases we have gone lower. I'm not suggesting that you do that, but certainly we've done cases as low as 20, 15, or sometimes there have been instances of even 10 where we have gone ahead and immediately temporized and kind of read the riot act, if you will, to patients about what to do. I was asked about the socket shield. The labial part of the root became loose. Do you remove it or do you just leave it in situ? And this is a great question. As I mentioned, unfortunately, I don't have experience with this. It's something I'm really looking forward to continuing to learn about, because I think that anything that can improve upon what we're already doing is something worthwhile. What was done in this case, when it becomes loose, as far as I understand, that you should be removing it at that stage in the game. Another question: if you have thin tissue, is it possible to just place a bone graft in order to thicken the bone so the implant doesn't show through? So I think that there's a few parts to this question. You saw in a lot of my cases that I favored, from a simplicity standpoint, just using a particulate graft. There are many who advocate the use of a connective tissue graft associated with every single implant that's placed immediately in the aesthetic zone. And as I said, this may be something that I'm kind of growing towards. I'm certainly not one to cut corners. I don't want to put patients at risk for aesthetic failure. But ultimately, my guideline, or my kind of indication, is with thin tissue. I do feel like that is the cutoff for where I will introduce a connective tissue graft or soft tissue augmentation. So whereas it may be possible to simply do a bone graft, there's two concerns I have. One is that if you've ever used a graft in conjunction with thin tissue, there are cases where even particles can exfoliate through the buccal portion. Some people, I've heard them call it like popcorn grafts. So having thick tissue is truly important. And remember, for the most part, the cases I was talking about did have intact buccal plates. So we're not talking about reconstructing the buccal bone. We're simply talking about the tissue that's almost coronal, because there's always a portion when you take a tooth out where the crest kind of ends and just soft tissue begins. And you can thicken that potentially in two ways. One is by using the graft, as we mentioned, in a dual zone fashion, or the other is in conjunction with a soft tissue graft, which I think is important when the tissues are soft, when the tissues are thin. Do you take an impression before extraction and pour it up to make an index for your temporary crowns? So our temporary crowns used to be fabricated in an analog fashion. We took alginate impressions, and sometimes, depending on the status of the patient, whether the consultation was done well in advance or what we call the same day therapy, a patient presenting with an emergency or wanting to get everything done in one go, where they'll literally come, a half an hour before their surgical appointment, and then the laboratory fabricates this. And of course, I talk about being spoiled working in a setting that's very directed toward this type of immediacy. And, it is something that can be done chairside, but it's just a little bit more challenging and time consuming to do at a high level. Now we are actually, for the most part, scanning. So there's digital scans which are being taken, and the laboratory is having some of these temporaries created from those models that are created. So it's not still entirely digital. We're not cutting resin blocks in order to create our temporary restorations, but they are being fabricated in advance of the patient. A good question from Dr. David C. Is anterior immediate implant placement a good candidate to work with a surgical guide? Thank you. So, what I've shown you and what I'll talk to, certainly an area that I think that I lag is in my digital or guided workflow. And I admit to that. And I think it's something that I need to catch up with. But something that's very key is that whether we're doing this through formal guidance, you need to be making sure that you are having some sort of prosthetic reference. So people throw around the term prosthetically driven implant surgery. Now, whether you are using adjacent teeth, whether you're using a guide, true guidance through sleeves, or in our case, because we have a temporary fabricated for just about every surgery that we perform, I am usually using that, resting it, either holding it, or sometimes through friction fit between the interproximals, I'm placing that temporary physically, and I'll actually begin my osteotomies utilizing this within the mouth to ensure that I'm coming up in a prosthetically favorable position, which of course is trying to come through the cingulum in order to ensure that we can have a screw retained crown. We can get away with a little bit of leniency when it comes to buccal inclination, especially because the thickness of a resin is not as important in the temporary state. And then, different angulated type abutments can be utilized in a final state if necessary, but some form of guidance, whether it be truly digitally guided or whether it be aided, like in the circumstance where I'm using something that shows me the endpoint, I think that you should have something along these lines as opposed to just strictly freehanding. Just seeing if there's any other questions we haven't gotten to. Oh, I was asked, this is a good one from Dr. Michael Fitterling. You seem to have placed the graft material prior to making the provisional. How do you keep the graft material out of the implant? So the provisional, the shell, the starting point is already made prior to the surgery. But you're right in that we take the tooth out, we put the implant in, we place the impression coping, the temporary coping onto the implant, and we pick it up essentially using flowable solution, and then it's given to the lab to convert or to transition. During that time, I know many will put a healing abutment or a cover screw on. What we find to be the best, because it doesn't obstruct anything, is I actually use the implant driver. And I use the long implant driver because it's narrower at the neck. And I simply place that in, and that allows me to not only condense, but to over condense the graft, because it's flush with the entire collar. And I'll take that out, then I'll replace it with a healing abutment while the patient waits, some 20 minutes or so while the lab is doing their magic. And then I just carefully remove that and then ensure, of course, there's no particles getting into the actual hex or into the connection. And we just go ahead and go forth, as you saw in some of the videos, and seat the temporary that has been fabricated. So I think we have time for maybe one more question here. Let me just work my way through. So I was asked by another doctor, what's the minimum or maximum gap for immediate implant placement if we do not want to compromise on the diameter of the implant? So there is no minimum or maximum gap relative to the size and the size of the implant. One thing that I didn't dwell on quite so much during this webinar, but I think is a really important point, is that there is a big movement, I believe, amongst most of us who are implants in general, and certainly immediacy, is that using narrower diameter implants, especially in the Straumann line of implants, where rock solid has long been shown to have great biomechanical strength properties, even in going back to the BLT implants or the BL implants, where 3.3 millimeters was shown to have very similar properties to that of the regular connections, like the 4+ implants. So for me, the reason and the rationale for using a narrow implant is a few-fold. One is that when you're creating your osteotomy and you're doing it palatally, you are actually starting, as you increase the size of the osteotomy, to encroach on the socket proper, if you will. And as a result, there's a higher chance of breaking into it, in which case the implant will no longer engage just in the osteotomy, but would enter into the main portion of the socket where you won't get stability and it won't be in the right prosthetic position. The other reason for a narrower implant is that we want to have room for more gum and more bone surrounding the implant. We know that greater distance to a degree between implants and other implants and implants and teeth will deliver a higher probability of maintaining soft tissue and hard tissue architecture, so papillary form and things that are involved in aesthetics. From a buccal standpoint and buccal thickness, you can imagine that the smaller diameter implant that you use, the more gap that you will have to the buccal plate. And as a result, you are essentially actually making your buccal bone even thicker because there's even more of a space to fill with graft. So, I mean, there's a handful more questions, but I think we're going to cut it off as we near 8 o'clock. So I just want to thank everyone again for their time, for their attention. Please do feel free to reach out to me. As I mentioned, at Dr. Phil Walton is the easiest way to get in touch with me. If you have any questions about this lecture or any of my other work, and I wish everyone, of course, at this time, we have to say, stay safe. I hope everyone's safe and healthy in their families, and things are well in the parts of the world that they're living in. And I thank you again for your time and for your attention.